So this is just a quick schema of how it works. Essentially, opiate receptors are just like those dopamine receptors. They bind opiates, send a signal as a G protein coupled receptor. Naloxone is just a drug that sits in the same place that opiates do on the receptor, but it doesn't turn the receptor on. And it will knock the other drugs, the other opiates off of there, thus reversing the effects and eliminating the overdose symptoms. So the reason why this is so effective is that typically opiate overdoses don't happen like this. It's not like you take the opiate and you just drop dead. Most of the time with opiate overdoses, people take the drug. It slowly builds up over time. They get kind of sleepy and groggy, and they don't feel very good. A lot of times they will just decide they're going to go to bed, and then they never wake up, right? Because the dose keeps building and they overdose. So trick is there's usually quite a big window where you could rescue somebody if you knew that they were having an overdose. Naloxone acts really, really quickly. Usually it says usually within 5 minutes, usually even faster than that. But the effects, as I said, start to wear off after 30 minutes and are completely gone after 90 minutes, which is a lot shorter than the half-life of most opiate drugs. Yes? You can keep rescuing people. I would never use it as a detox. No. I mean, so if you have someone overdosing, you can give it to somebody overdosing. If they start overdosing again, you can give them more for sure, right? Yes, so you can keep giving people naloxone until their opiate wears off. But yeah, don't use it as not as a detox treatment. Yeah, absolutely. You can repeat the naloxone as many times as you need in order to keep people from overdosing and dying. We have had funny, talk to some parent who had been given it wanted it so that they could test to see whether their son who was using drugs, because they didn't trust him, so we're gonna shoot it up his nose when he was sleeping to see if he went into withdrawal because they didn't trust him, stuff like that. I was like, oh my God, no, not that. But yeah, so there are people who've come up with bizarre uses. Don't let them go there. Okay, so one big problem with overdose is that oftentimes people are not comfortable. They don't call emergency services, either because they're afraid that somebody's going to maybe they were doing something they knew they weren't supposed to, and they're afraid they're going to get in trouble, or maybe they just think they're taking care of it because people will look revived. I mean, they literally come back from life to life. And people think, oh, we don't need to go now. Those are substantially problematic. The cool thing about naloxone is it does almost nothing to an opiate-naive person. It's very, very safe. It doesn't have a lot of drug interactions. So if I were to come up and give anyone naloxone who wasn't on opiates right now, it really wouldn't do anything. So it's very, very safe, which is why everyone feels pretty comfortable just handing it out, right? Hand it out, keep it in your medicine cabinet. You may never use it. Hopefully you'll never use it, but if your toddler comes in and shoots it up their nose by accident, it's okay. They'll live. Not if they take your pain pills, but if they play with your naloxone, it's okay. So what they found essentially is, well, one, the sooner you use the naloxone, the less morbidity you get. So one of the things that goes along with all those overdose deaths are there are also people who just spent a lot of time anoxic and have a whole variety, have brain damage, other problems related to having been an overdose. So the sooner you get the naloxone in the person, the better off they're going to do. And the cool thing is training is people have come up with training models that are really, really short. So this has been done successfully. I've seen it done with 5-minute educational interventions where they teach you how to recognize it, do a demo of how to use the product, and there's a variety of products, and people can very successfully use it. There's a new product now, an auto injector, which is super fancy and cool but kind of expensive, that It has all the instructions and training on it. All you have to do is take it, press a button, and it'll walk you through exactly what you have to do. And you just basically stick it on somebody's leg, and it takes it from there for you. And they've shown that you don't even need to train people on that. You just have to have them know when to use it, essentially. So I've seen other models where they just hand the kit and the DVD to people, and that seems to work okay. That one makes me nervous because I don't know that people watch the DVD, but apparently they do. So it's not hard to implement. And I'm going to go through this really quickly, but as I said, this really started as a public health model where community, usually harm reduction groups, distributed naloxone and did overdose education at needle exchange programs and other substance use treatment programs sometimes. And through those programs, they've been able to show substantial effectiveness and cost effectiveness as well. And I'll go through that really quick. That's been expanded in some places to, instead of just giving naloxone to substance users, they gave it essentially to anybody who asked. So if you thought you knew somebody who was at risk of overdose, you could come get it. State of Massachusetts, for example, did a big program this way. And that showed, they were able to show that counties that implemented that program actually saw reductions in overdose death rates, which was fairly cool. And more recently, there's been a whole variety of healthcare systems that are starting to distribute naloxone for patients with prescription opiate problems and in their substance use treatment programs. And I think the first example of this was all of Scotland implemented a healthcare-based program. There's also Project Lazarus, which was started, I think, it's one of those southern states. I'm blanking on it right now. And then VA has started a national OE&D initiative in the last 2 years and has distributed a lot of kits. So the trainings, generally, they need to include trainings on overdose risk factors, prevention strategies, recognizing an overdose, how to respond to an overdose, which includes first trying to wake the patient up. So doing what they call a sternal rub, which is basically you stick your knuckles into somebody's sternum and cause some pain in hopes that will revive them. Call 911, administer naloxone, and use rescue breathing as needed until they revive. So that's the essence of the training. They issue the kit to the patient. This is just some studies of effectiveness. So in the state of Massachusetts, this is all of the programs. So they had looked at across all of the public health programs. They distributed 53,000 kits and had 10,000 overdoses with them, which I find just, if you look at that, 1 in 5 of the kits that were sent out were actually used to save a life. That just goes to show you how at risk, particularly those populations where people knew when they were at risk and got the kits. Obviously, those rates are not going to stay as high if we start taking a much more broad healthcare-based approach. And so the place where I think we're a little bit stuck right now is for these types of programs, there's huge evidence for cost effectiveness. So the amount, it's something like $11,000 per life saved or something for counting all of the distribution and the health and the delivery and the kits and everything. That number is obviously going to go down the less effectively the kits are targeted, but when you go for normal cost thresholds for life saved are somewhere in the $5 million range. So there's a lot of room for distributing these to other populations without running into arguments against the cost. Could we turn the air down? Sorry. Okay, we got some cold people now.
I knew that was going to happen.
It's okay. So I will say there's a few various models that have been set up to do this in healthcare systems. I'm I'll talk about the VA one because that's the one I know the best. Essentially what they did, they took all the naloxone kits and devices, put them on formulary so that they're available to any provider who wanted to prescribe them, and recommended prescription of these kits to any at-risk patient based on provider discretion. So if you thought that the patient had a good reason to have a kit, you could give them, you didn't have to get too fancy on justifying them. And some of the stuff that I point out that people don't always think about, besides the patients that we talked about, anyone at risk of addiction, anyone addiction or suicide obviously should get a kit, as well as people with overdose risk. I would argue too, you know, if you've got somebody who's worried about a family member, right? They think their son's gonna steal their meds, or their, you know, wife is gonna take some and overdose. Give them to them too. It certainly may not technically be treating that patient, but it's gonna make them feel a lot better if they save their loved one's life, and I can promise that will have impact on their pain downstream. So not a lot of data on outcomes of these, except that we know they do in fact get used. So in the VA trial, we were getting reports back of about one spontaneous report, so people just calling us, telling us about one out of every 100 kits was used for overdose reversal. So again, not remarkably high rate of use, even in a somewhat lower risk population. So these are your options for kits. There's that fancy auto injector I told you about that's made by Evzio. There's a recently approved intranasal spray which they bought the name Narcan because everybody knew it already. So it's called Narcan. That one's substantially cheaper than the auto injector, but they both work very effectively. Also, all of the research has been done, and you can still assemble your own kits if you want to save a little money, but waste a lot of time. So in those cases, you just put together kits with training materials, with naloxone, plus either needles and other things to help with safe injection for IM injection, or a syringe and an atomizer. So they have nasal atomizers that can be used with your standard naloxone drugs. Okay, and I'm not going to go through this, but I'm not going to actually show these videos. But if you want more information, there are these links right here have example clinical discussions. They walk through a patient case. This is how to talk about it with a patient. These are the things to bring up for both somebody who is using for pain and somebody who has an addiction problem. There's a demo of how to use self-assembled kits. And then there are a whole variety of patient testimonials about their experience with receiving the kits and either saving them, having someone save them, or saving other people, or in some case both. So one thing I will say is people who've rescued patients, other people from these, and people who have been rescued, we've found that it's a very transformative experience in most cases. I know there's been people who've been hesitant to do this because they worry as I said, it's going to increase risk behavior, or it's going to cause problems. What we found is that people who have actually wound up using them, it's often a trigger for, making substantial changes in substance use behaviors, getting yourself into treatment, whether you saved yourself or somebody else. Just watching someone get that close to death, really brings things home for people. It's also been can be really motivating. Like anything where you're that close to life, like really makes people think. And we found that it's been very, very moving in positive ways for people who've experienced it. Any questions about that before I? Yeah.
Just one quick comment that it's kind of interesting that just yesterday was the report about the coroner's report on Prince's death.
Yeah.
And that possibly the addiction specialist who was called in was at the door of the elevator with something, maybe it was naloxone, I don't know what it was. But this is like a textbook case of somebody
Who could have been saved with naloxone. Yeah. Yeah, if somebody was there, and I mean, why anyone would fly their naloxone in from California if that's what he was trying to do, I am not quite sure, but
I don't know if that was the medication that was mentioned, but I don't remember it.
yeah, it is very likely I mean, that's what you save people with. There's also lots of efforts right now to try to make sure that all police have naloxone in their car. All emergency personnel have access to naloxone because the risks are so high. You want to make sure your first responders always have it available. We've also putting naloxone just like, on the walls of hospitals and things like that. Also highly recommended. So, and I think even some school systems have started stocking it, in the school office and things like that. It's just a way, better safe than sorry. I guess the other thing, it's now being carried at CVS's. They're trying to get general it available over the counter, I guess not under the counter, behind the counter, for patients. So it's not in every state now, but a lot of places have models where the clinical pharmacist can write a prescription like a blanket prescription that covers all patients, so that they can just prescribe it as people come in and ask. So I'm pretty sure, I haven't checked exactly where they're being covered, but California does in fact have a pharmacy. You can go get them at the CVS if you want. There's also if you search, there's also a finder for overdose education and naloxone distribution programs. So those community programs that will distribute the kits for free. So if you have anyone who's not getting them because they're worried about the cost, you can always refer them to one of those.